Hello, my name is Richard Voigt, and today I'll be discussing an external validation of syncope prediction rules in older adults. Let's begin by discussing some background information related to this topic. Every year in the United States emergency departments, there's over 1 million visits for syncope or near syncope. These visits and associated hospitalizations result in over $2 billion of healthcare expenses yearly. The differential diagnosis for syncope is quite broad, ranging from benign to true life threats such as cardiac arrhythmia. In all comers, the admission rate for syncopal presentations to the emergency department is roughly 30%. However, in the geriatric population, this value is greater than 50%. In 2019, Probst et al. Set out to determine if there was any clinical benefit for hospitalization in the geriatric population presenting to emergency departments with syncope without an identified cause. They found that at 30 days, there was no clinical benefit for patients who had been hospitalized versus discharged home. Because of the difficulty in risk stratifying patients, multiple risk scores have been developed to help assist clinicians in making these difficult decisions. The objective of our research was to evaluate and externally validate the San Francisco Syncope Rule, Canadian Syncope Risk Score, and the FAINT score in older adults. We set out to perform an observational cohort study of consecutive adults greater than the age of 60 presenting with syncope or near syncope to our academic emergency department. We applied these patients' data to our original risk score criteria, except for the FAINT score, which I'll dive into more later. The primary outcome of our investigation was 30-day serious outcome, including death, serious cardiac outcomes, pulmonary embolism, aortic dissection, clinically significant bleeding requiring transfusion, or need for CPR within 30 days' time. We began with 309 consecutive visits and excluded patients for the following reasons: transfer from outside hospital, severe intoxication, seizure, stroke, head trauma, or ongoing altered mental status or confusion. We also eliminated patients who had an identified adverse outcome in the emergency department, as well as patients who were lost to follow-up. Of the remaining patients, 24 had a serious outcome within 30 days, as identified by the criteria previously mentioned. When applying the 160 cases remaining in our cohort, we found that the San Francisco Syncope Rule showed a sensitivity of 83%, negative predictive value of 90%, and negative likelihood ratio of 0.6. This syncope rule is arguably the most historic, although has shown poor external validation in previous studies. Next, looking at the Canadian Syncope Risk Scores performance in our external validation, we note a sensitivity once again of 83%, with a similar negative predictive value and negative likelihood ratio in comparison to the San Francisco Syncope Rule. The Canadian Syncope Risk Score can be somewhat controversial as there are multiple subjective factors taken into account when utilizing this rule. The final clinical decision rule that we attempted to externally validate was the FAINT score. Out of the 3 scores we examined, this one is probably the least familiar to providers. It was published in February 2020's Annals of Emergency Medicine and was derived only using geriatric data for patients with syncope. Part of the criteria for the FAINT score is use of NT-proBNP, which the majority of our patients did not have data for during our analysis. Excluding the NT-proBNP, this syncope risk score had a favorable sensitivity, negative predictive value, and negative likelihood ratio during our external validation. In summary, clinical decision rules should help assist providers in risk stratifying their patients during their workup and disposition. The rules that we examined today should be used for screening tools in helping providers determine which patients would potentially suffer an adverse 30-day outcome and ultimately to help provide guidance in disposition. Ideally, Screening tools would have a high sensitivity, high negative predictive value, and strong negative likelihood ratios. Among the tools that we examined during our analysis, the FAINT score, even exclusive of the NT-proBNP, had superior sensitivity, negative predictive value, and negative likelihood ratio in comparison to the San Francisco Syncope Rule and Canadian Syncope Risk Score. With that being said, clinicians' decisions should also rely on additional factors such as patient access to healthcare, healthcare literacy, and social determinants of health in making these difficult decisions. To expand upon today's presentation, our goals for the future would be to continue external validation with a larger sample size, evaluate various timelines for potential outcomes and decision rules, and to possibly even attempt additional decision rule derivation. And with that, I'd be happy to take any questions from the audience. Thank you.
Good afternoon. I'm Dr. Sano. I'm an emergency medicine physician at Columbia University Medical Center. Our project that I'm going to describe today, telemedicine used by older adults in a COVID-19 epicenter, was developed by both myself and Dr. Trong, Haravian, Olson, Kenny, and Benton, all of us emergency physicians at Columbia University Medical Center. As a bit of a background, as of April 1st, 21, there have been 2.8 million deaths from COVID. In the US, accounts for over 550,000 of these deaths. In the spring of 2020, New York City was the epicenter of the pandemic. Geriatric patients were at especially high risk. By June 2020, the New York City cumulative death rate by age greater than 75 years, 1535 per 100,000 population, and in the 45 to 64 age range, 187 per 100,000 population. The graphics here display both the time range of the surge and also the burden of death by age. Of course, there were multiple efforts to keep people from using the emergency department unless they needed emergent health care. Telemedicine was just one of them. There were both tents in Central Park. The Department of Defense sent a Navy hospital ship, and our own institution used a pre-triage tent with family physicians to screen patients who were ambulatory and could be discharged without being seen in the emergency department. But telemedicine was also used as a tool to shift non-emergent care from our overburdened emergency departments and to provide routine and urgent health care to a community that was in lockdown and often fearful of seeking care. While offering the ability to reach many patients, remote healthcare options presented unique challenges due to technology requirements and also visual, hearing, cognitive, and language limitations that were present in our diverse, multilingual older adult community. Our study's goal was to evaluate the use of remote healthcare during the pandemic at our institution. We compared the frequency of use during the flu season with a similar interval during the pandemic. The objectives of the study were to evaluate the use of remote healthcare and provide a descriptive analysis of this vulnerable population during the peak of the COVID-19 pandemic. This was a retrospective chart review, and we included patients 65 years of age and older that were evaluated via our direct-to-consumer telemedicine platform during the surge of the pandemic from March 1st through April 30th. A data extraction tool was developed and performed by 6 emergency physicians with a descriptive statistical analysis. This graphic really displays the change of the use of telemedicine by older adults in December during the flu season, and then again in March and April. So pre-pandemic from December 1st, 2019 through January 23rd, only 7 patients older than 65 utilized telemedicine. During the pandemic, from March 1st through April 23rd, 130 patients in the same age group, a 20-fold increase, utilized our telemedicine services. Some of our descriptive results. The mean age was 73. 20% of the patients in the cohort were advised to seek emergent care, with a female majority, mainly English speaking, with a predominance of visits for concern for COVID. And the majority of the patients in our data set did not need or use assistance using the telemedicine platform. 92% of the patients did not use telemedicine in the 3 months prior to the present encounter, and 22% of the encounters need an emergent ED referral for further evaluation. The median age of those referred emergently was older, i.e. 78, versus the routine follow-up, which was 70. Those over 75 were more likely to use family assistance. So there was an exponential growth of telemedicine utilization during the pandemic. Telemedicine is an acceptable alternative access to care, and it has potential. There's a need for telemedicine provider training in triage and emergency medicine, and there has to be a knowledge of the local resource availability. The limitations. Access to the platform data was lacking, and so we didn't get to count the calls that were dropped. Limits to individual clinic notes. We had to get our information from what was charted. I'm going to be able to take some questions from you once this session is completed. Thanks for your time.
Hello, my name is Sean Liu, and today I'll be speaking about ultrasound-measured sarcopenia and grip strength among older adult fallers in the emergency department. We have no conflicts of interest to declare. Falls are the leading cause of traumatic injury in older adults. Sarcopenia, the loss of muscle mass and strength, is associated with an increased risk of falling. Identifying ED patients at high risk for falling is central to preventing future falls. Point-of-care ultrasound, or POCUS, is a promising, innovative method of assessing sarcopenia. However, no study has used POCUS in the emergency department to correlate muscle mass and grip strength with previous falls. Hence, our objective was to compare muscle size and grip strength among older ED patients who have fallen within the past year versus older ED patients who have not fallen within the past year. In terms of our methods, this was a pilot observational study at a single academic tertiary hospital. We had a convenient sample in that we recruited patients between Monday through Friday, and we included patients who were greater than or equal to 65 years of age and who were admitted to the ED observation unit. We excluded critically ill patients and those who were at high risk for COVID-19, those who were cognitively impaired and unable to consent. Our primary outcome was self-reported falls within the past year. And we had 3 predictor variables. 1 was the biceps brachii muscle. 2 was the thigh muscle, which included the rectus femoris and the vastus intermedius muscle. And 3 was grip strength, which we measured using the hand dynamometer. We used univariate logistic regression for data analysis. In terms of our ultrasound technique and equipment, all investigators attended a 2-hour training session in order to go over the landmarks in our study. For the biceps brachii muscle, we used the midpoint between the acromion and the elbow crease in order to measure the biceps thickness. For the thigh muscle, which included the rectus femoris and the vastus intermedius, we used the midpoint between the anterior superior iliac spine and the proximal patella. And these landmarks were based on previous literature. We found excellent reliability between our investigators and that our interclass correlation was calculated to be 0.92 with a p-value of 0.4. 0.04. In terms of ultrasound technique and equipment, these were our ultrasound measurements. We use for the biceps brachii, we measure between the soft tissue and the humerus, and for the rectus femoris and the vastus intermedius, we measure between the border of the soft tissue and the femur. And on the right, we have our hand dynamometer. In terms of results, 49 patients were enrolled at the time that we submitted this abstract to SAEM. 27 patients were male, which represented 55% of our sample size, and 29 patients, or 59% of our sample size, had fallen within the past year. In terms of logistic regression and our outcomes, our mean biceps thickness was 2.27 plus or minus 0.62 centimeters, and our odds ratio was calculated to be 1.08 with a confidence interval of 0.43 to 2.73. Our mean thigh muscle thickness was 3.08 plus or minus 1.05 centimeters, and our odds ratio was 0.79 with a confidence interval of 0.45 to 1.37. Our mean grip strength was 23.1 plus or minus 9 kilograms, with an odds ratio of 0.99 and a confidence interval of 0.93 to 1.05. Based on our regression analysis, we found no association between bicep size, upper thigh size, grip strength, and being a faller. So in conclusion, our study found no association between POCUS measured muscle mass or grip strength and being a faller. Previous studies found ultrasound measured muscle quality did predict falls within the previous 12 months, but these were healthy women and were recruited in the outpatient setting. Our limitations included the following. This was a small sample size as it was a pilot study, and it was limited to the ED observation unit due to the COVID-19 pandemic. And hence, these patients did not necessarily represent our standard geriatric ED patient. Furthermore, we relied on self-reported previous falls. In terms of future work, our study now has 116 subjects. And we also are including a prospective study, which will be examining whether muscle mass and grip strength are associated with future falls. Overall, larger studies are needed to better explore the use of ultrasound in assessing sarcopenia and predicting fall risk. I'm happy to take any questions. And thank you so much for your attention.
Hello, my name is Pete Serena, and I'm coming from Northwestern Emergency Medicine Residency Program, and I wanted to talk to you today about the development of the admission for geriatric patients in the emergency department age score. I think this is a super important topic because as the US population ages, we're going to have more and more frail older adults coming into our emergency departments. These older adults are at higher risk for ED visits, hospitalization, disability, and death. EDs were not originally designed for older adults. And by that, I mean patients come in and they have an acute complaint like falling down, but we're not addressing that kind of underlying problem, the chronic problem. Why did the patient fall down? Did he slip because he needs a walker instead of a cane? Does he need home health? Does he need access to a geriatrician? There's a lot of really exciting new geriatric specific interventions that are happening in emergency departments. Specifically at Northwestern, we're doing something called the Geriatric Emergency Department Innovations Program, where geriatric trained emergency medicine nurses actually go in and start working on transitions of care with patients. They talk with patients and their families and identify things that could really help them, like access to resources like home health or physical therapy or seeing a geriatrician. But the problem with that is that it's very expensive and time consuming. So who would best be served by these interventions is a key question. There's been a lot of different risk stratification tools looking at vulnerability in the emergency department specifically. It's something that's been a real priority for the geriatric emergency medicine community. ISAR is something that's been used in the past, TRIST, and most recently, clinical frailty scale has shown a lot of promise, but there's still only moderate predictive accuracy when thinking about important outcomes for older adults. The point of this study was to create an algorithm to risk stratify these patients and identify who would best be served by a geriatric specific intervention in terms of who's going to go home versus who's going to be able to go to who needs to be admitted. The way that we did this was we identified all older adults in our emergency department for over 4 months in Northwestern. We collected 36 variables upon presentation. This included clinical frailty scale as a marker of vulnerability, the estimated severity index, which is more of a marker of the acute condition that the patient was coming in with to begin with, demographic information, as well as information like prior hospitalizations, prior ED visits, vital signs upon presentation, and comorbidity information. Specifically, we looked at information on comorbidities from the Charleston Comorbidity Index. We also looked at patients' chief complaints, and we coded those into 25 different chief complaint categories that were specific to our geriatric population. Ultimately, our outcome of interest, primary outcome was admission on that presentation. We also had secondary outcomes of interest, including subsequent admission within 30 days, as well as subsequent ED visits within 9 days. We used a 5-fold cross-validated relaxed lasso logistic regression because we were very interested in all of these variables. However, we did not want to overfit our model. So here's the results, preliminary results from our study. What we have is on the left is a ROC curve looking at the predictive accuracy of different gradations of our age score. So specifically in salmon, we see the CFS score with an AUC of 0.67 cross-validated. That's statistically similar to the ESI score, but then when you start adding those together as well as demographic information in the blue, it gets better. And then the most predictive actually was the age score. This was what we expected, but I also wanted to check against what was seen in the literature previously. So the Capelli article in 2020 was in a different population than our own, and they had an AUC of 0.72 for admission. This compares to what we saw in our own population in our article from 2020. The final thing that's mentioned here is the La Mancha article, where they did a risk score where they looked at, which ultimately included vital signs as well as chief complaint in the estimated severity index, but did not include any sort of marker for vulnerability, which is why we think our age score is more robust than what they had presented in 2010. Ultimately, what we hope to do is further explore other secondary outcomes in this cross-validated space, specifically looking at the ED return visits, as well as admission within 30 days, because we think those are very important. A little bit harder to accurately predict, but still very, very important. We then want to validate this age score. What we've done is we've collected data prospectively within our same patient population, but we just want to make sure we did not overfit the data. We have IRB approval for this. And then our next step is to work with an EPIC and implement this age score into clinical care. What our hope is that we're going to be able to identify patients who would most definitely be admitted. And so there's really less of a concern for providing these community resources for them through our JEDI program, as well as patients who are definitely going to go home and don't really need these resources. So we can better target that patient population who would most benefit from our transitional care nursing team coming and speaking with them, as well as identifying what could help them. So I'm really excited about this research. I'm really glad that I had the time to speak with you about it. I also want to take the time to thank my research team who've been working really hard with me. And I really look forward to SAEM21 and talking more about this project and hearing everyone's feedback. So thank you so much for taking the time to listen, and I look forward to speaking with you all soon.
Good afternoon. I'm Dr. Ellen Ciano. I'm an attending physician at Columbia University at the Department of Emergency Medicine. I and my co-authors have no financial conflict of interest to disclose. As a bit of background, on December 31st, the World Health Organization had reported over 1.8 million deaths due to COVID-19. And now, on April 1st, over 550,000 of those deaths occurred in the United States. In the United States, over 95% of all COVID-19 deaths have occurred in those older than 50 years old age. Environmental factors play an important role in outcome. Early reporting showed lower than expected mortality amongst homeless individuals, while long-term care facilities account for 40% of all COVID-19 deaths nationally. Early reports pointed to increasing prevalence of COVID-19 within areas of increased density, but less is known about the effects of housing density, working outside the home, and the presence of home health aides on outcome from COVID-19. The red arrow points to a light green area that represents the neighborhood from which most of our community dwelling patients come from. This is a neighborhood with many multi-generational households. This is a graphic that represents citywide COVID deaths by date. And this really represents the first surge from the end of March, the beginning of May in 2020. But it also correlates with our highest hospital volume of COVID-19 patients. And the red arrows on this graphic represent the dates included in the chart review. The objective of this study was to describe outcomes, including hospital admission, length of stay, level of ventilatory support, and mortality based on pre-admission housing status in older adults seen in our emergency department with COVID-19 during the spring of 2020 in New York City. We conducted a retrospective chart review of all patients aged over 55 with COVID-19 diagnoses seen in our Northern Manhattan Emergency Department from March 28th to April 8th. These dates define the time period where cases peaked in our hospital and New York City. Demographics, comorbidities, oxygen and ventilatory requirements, ICU, and hospital length of stay was obtained by individual chart review and extracting from available notes in our EMR, including all admitting notes. A COVID-19 case was defined by the ED physician's clinical impression or a positive COVID-19 PCR test. Patients who were discharged were not routinely offered COVID-19 PCR testing. So a chart level review defined only 921 of the initial 1,161 charts to be COVID-19 diagnosis. Pre-admission housing status showed that 81.4% of those patients lived in their home and 1.4% were undomiciled. 16% came from long-term care facilities. Overall mortality was 29%. Mortality of those that came from long-term care facilities was 47%. The relative risk of death admitted from a long-term care facility versus home was 1.67. When adjusted for diabetes and hypertension, the relative risk for long-term care facilities associated with death was not significant and was equal to 1.39. So, consistent with other reports, older adults who reside in long-term care facilities have the highest mortality rate. When adjusted for comorbidities, though, the relative risk was not statistically significant. This reinforces the concept that the long-term care facility's high mortality rate lies in the high rate of COVID-19 exposure from staff, visitors, and other patients. Undomiciled and incarcerated patients represented an insignificant number of the overall cohort. This may be attributed to the New York City's successful diversion of undomiciled individuals to alternative housing sites that allowed for greater social distancing. There were some limitations from our study. I've presented preliminary data analysis in the abstract today. In addition, we are limited to those patients that were actually seen in our emergency department and may not reflect the community-wide outcomes. In addition, readmission or deaths that occurred at outside hospital or long-term care facilities were not included in outcomes in this study. Thank you for your time, and I will take questions at the end of this discussion section.
Good afternoon. My name is Jessica Stanich, and I am an emergency medicine physician in Rochester, Minnesota at the Mayo Clinic. Today, I'm going to speak to you about research we conducted, which showed that altered mental status as a chief complaint is linked to increased death at 7 days of an emergency department visit. I have no financial disclosures. Patients presenting with altered mental status are typically assigned a lower acuity triage score, but we thought their outcomes might be worse. We studied 5 chief complaints: altered mental status, chest pain, abdominal pain, weakness, and headache. We conducted an observational study over 1 year in an academic emergency department and studied patients greater than or equal to 40 years of age. Log rank test, Cox proportional hazard models adjusted by age, and hazard ratios were calculated. A total of 10,000 emergency department visits were included. Total deaths were around 100 or 1% in 7 days following the emergency department visit. Mortality rate for altered mental status was greater than any other chief complaint at 3.2%. This was compared to chest pain, 0.7%, abdominal pain, 0.9%, weakness, 1.5%, headache, 0.5%. I think when we see a patient with a chief complaint of chest pain, we think of myocardial infarction. Abdominal pain, you might think of appendicitis. Weakness in the elderly population, I think could almost be anything. This study, it's important to note that this was an age-adjusted study and abdominal pain acted as the reference group. There was no difference in the risk of mortality for patients presenting with chest pain, weakness, or headache compared to abdominal pain. However, patients presenting with altered mental status had a greater risk of death within 7 days of that ED visit. This figure essentially demonstrates the same information. The light blue line is altered mental status confusion. Again, reference comparative group is abdominal pain, and the other chief complaints, chest pain, headache, and weakness. So why does the chief complaint of altered mental status have a worse short-term prognosis? Is it because brain dysfunction is the key marker of end organ failure, maybe more important than the heart? Were the majority of these patients frail? Is it the etiology being toxicologic or neurologic in terms of stroke or hemorrhage? Were these patients delirious? We know that delirium carries a high mortality of almost 30%. Did we miss delirium? Prevalence is 10% in our emergency department population, and we only detect it around 1/6 of the time. Were these patients discharged versus admitted? We included both. We adjusted for age, and so we can't blame this finding on age alone. I wonder if our younger group, because they still had a higher mortality at 7 days, were also frail. So in conclusion, patients presenting with a chief complaint of altered mental status have a worse short-term prognosis. If the patient's being admitted, this needs to be documented. I think oftentimes the patient presents with confusion. We may find their urinary tract infection or hyponatremia, and often forget to include that the patient was confused when they presented in our handoff. If delirium is present, it must be communicated to the inpatient team, as there are specific tasks that can be done to try to lower their risk of continuing to be delirious or improve it. Discharge planning needs to be different. Close follow-up may be needed. Strict return precautions, specifically around delirium, should be conveyed to family and care partners prior to discharge. Now we have our review question and time for discussion. Which of the following chief complaints is associated with higher risk of death 7 days following an emergency department visit? Thank you.
Good afternoon. My name is Sarah Keene, and today I will be presenting data on the cost savings associated with a geriatric emergency medicine assessment team. Geriatric patients make up an increasing number of patients who present to emergency departments, and an even larger percentage of those patients who end up admitted to the hospital. Older patients also have a notably longer average length of stay while in the hospital compared to younger patients. Because most geriatric patients are on the government-funded health insurance program Medicare, the hospital stays of geriatric patients are a significant contributor to the cost of healthcare in the United States. Prior work has demonstrated the ability to reduce hospital length of stay and attendant costs through the implementation of geriatric-focused programs in the emergency department. At Beaumont Hospital, we implemented such a program in June of 2019. Our program, the Geriatric Emergency Medicine Assessment, or GEMA program, consists of an advanced practice provider, a geriatric care manager, and occupational therapy as appropriate. This program was implemented at a busy suburban emergency department with an annual census of approximately 120,000 people. Patients qualify for GEMA assessment if they are 65 years of age or older and present to the ED during the hours of GEMA operation, which is Monday through Friday, 8 a.m. through 6 p.m. Patients who qualify are screened by the APP using the Identification of Seniors at Risk screening tool. If patients test positive on the ISAR, which is defined as scoring 2 or more points, then they are further screened by the APP and interventions are targeted as appropriate. Assessment includes screening for cognition using the short blast test, for delirium using BCAM, and for fall risk using the timed up and go test, as well as assessing for the ability to perform the CAT's activities of daily living and for polypharmacy using a chart review. Interventions that are available include occupational therapy assessment in the emergency department with additional PT/OT support if the patient is admitted, placement in a subacute rehabilitation facility directly from the ED, or initiation of the SAR placement process if the patient is admitted, arranging outpatient follow-up with the patient's PCP or the geriatric clinic, and delirium management as necessary. We have previously presented data on our pre-post pilot study, which looked at the first 6 months of the program from June 2019 through November 2019 compared with the preceding 6 months. We found a 25-hour reduction in hospital length of stay in this study, and importantly, we found that admitted patients did not differ in their underlying comorbidities as measured by the Charlson Comorbidity Index or in their severity of illness. We have continued the program, and here we present data from the subsequent year. When looking at November 2019 through October 2020, we found that GEMA-assessed patients had an average hospital length of stay of 4.75 days, and non-GEMA patients had an average hospital length of stay of 6.49 days. In total, the reduction in length of stay averages to 31 hours. This data does not include patients who were admitted to ICUs or who were admitted to the hospice service, and it also does not include patients who presented during the 6-week period from March 18th through the end of April, as the GEMA program was shut down during that time due to the COVID-19 pandemic. To determine the cost savings from this reduction in hospital length of stay, we first have to account for the cost of the program. Here you can see that the cost of the program is primarily staff salary. The APP, which is a full-time position, costs $12,000 a month. The geriatric care manager, which is also a full-time position, costs $7,391 a month. The program also requires supervision by a physician at a .2 appointment that amounts to $4,762 a month for a total program cost of $24,153. We found that occupational therapy was actually profitable because OT can bill for their ED consults. So after accounting for OT's cost, the total profit for the hospital was $2,396. This means that the net cost for the program was actually $21,757 per month. To calculate the total cost savings from the program, as mentioned, we found that there was a 31-hour reduction in hospital length of stay for assessed patients. Using a hospital-specific amount of $1,500 as the cost of a 24-hour inpatient stay, this comes out to $1,937 saved per patient. The GEMA program assesses an average of 141 patients per month who were admitted to the hospital, so there is an average savings of $273,187 per month. After subtracting the monthly cost of the program, this comes out to $251,430 saved per month, for a total savings of $3,017,166 per year. Of course, this number is dependent on how much it costs for 1 day of inpatient care. Instead of using our hospital-specific number, we also ran the numbers using the national average cost of 1 day in the hospital for the United States, as reported by the Kaiser Family Foundation, which is $2,517 per day. Using this amount would result in an annual savings of over $5 million instead. In conclusion, our geriatric emergency medicine assessment program significantly reduced the hospital length of stay for assessed patients, which is associated with a substantial cost savings. These results are in line with prior studies that have shown similar improvements in cost savings, and they demonstrate the financial feasibility of geriatric-focused interventions in the emergency department. And with that, I'm happy to take any questions. Thank you.
Good afternoon. My name is Gwen Jacobson, and today I'm going to tell you a little about how our interdisciplinary team designed and implemented a clinical decision support tool for automatically identifying older ED patients at risk of future falls and referring them for outpatient fall prevention services. Many of you may know that roughly 20% of all ED visits by older adults come as the result of a fall. Now, what some of you may not know is that about a third of these patients were seen in an ED during the 6 months prior to that fall. This highlights an important missed opportunity for ED clinicians to intervene, providing referrals for fall prevention services at those earlier ED visits and potentially decreasing fall incidence downstream. And we're fortunate to have effective fall prevention resources here, including the UW Health Mobility and Falls Clinic. The problem, however, was that ED providers were not referring anyone. We decided that the best way to approach this problem was to develop a CDS tool to automatically identify high-risk patients and allow clinicians to easily place referral orders. The first step was to develop an EHR-based algorithm predicting the likelihood of falling during the following 6 months. The reference for that publication is listed below. Then we defined the requirements for the CDS tool utilizing that algorithm. It needed to be designed specifically for use in an ED environment, integrating seamlessly into existing clinical workflows as well as into the EHR platform. We had to avoid adding any additional time burden, making it as automated as possible while still allowing clinicians to make decisions. It also had to be both trustworthy and easy to navigate. So with that understanding, we mapped out how the CDS would work. Shortly after arrival in the ED, all patients 65 and over are automatically screened based on information in their EHR and characteristics of the current ED visit. Now, if that algorithm assigns a risk score above a preset threshold, a falls risk alert will fire, appearing on the Dispo navigation screen. The clinician then chooses whether or not to place the referral order to the falls clinic. If they refer, language will automatically be included on the patient's after visit summary, describing the clinic and the scheduling process to be discussed with the patient during discharge. Now, there are many well-intentioned CDS tools out there, and you don't have to go far to find examples of ones that do what they're designed to do, but failed in practice due to poor adoption. So making the falls risk CDS effective required thoughtful design, meaningful collaboration, and a realistic implementation plan. We engaged an interdisciplinary design team from the get-go, a critical combination of ED providers, health services researchers, human factors engineers, and falls clinic staff. Importantly, we also partnered closely with our health system IT analytics team to work within our technological capabilities and constraints, rather than design something only to find out later that we couldn't build it the way that we wanted. We employed a rapid cycle development and evaluation process using a combination of human-centered design and implementation science strategies, facilitating simultaneous design of the technology and the intervention's implementation. This included identifying and resolving usability problems, assessing barriers and facilitators, and refining protocols for communicating with referred patients. We also engaged two types of end users. The first were ED clinicians, engaged through surveys, hands-on user testing, and educational sessions. And the second were patients similar to those who would be receiving the falls clinic referrals at discharge, which we did in partnership with our Hospital Patient and Family Advisory Council. Refinements to this were made for both the content and interface as the feedback was received, allowing us to engage in multiple user testing cycles. To demonstrate the value of usability testing, here is what the CDS alert looked like in the prototype. And here's what it looked like after we addressed user and design team feedback. There are many visual differences, including the text and color of the header, a shorter description with more bulleted text, an FAQ document, and a different configuration of buttons to encourage users to choose whether or not an order should be placed, rather than canceling the alert. We had high levels of feasibility and acceptance from our ED providers, and we were ready to launch our pilot. But that didn't mean that our job was over. Successful implementation requires continual monitoring. Since launch, we've employed a cyclical process for collecting data and using it to optimize and adapt the tool. To give you a short example, within a few months after launch, we determined that depending on how ED physicians navigated the dispo screen, the falls risk alert was not always visible to them. As a result, they could complete the discharge without ever being aware of the patient's high fall risk. After going through this process, we implemented a hard stop, essentially forcing users to acknowledge the alert before they could exit the screen. This data-driven optimization resulted in an increase in referral rates from 24% to 37%. So in conclusion, using a collaborative, interdisciplinary, and iterative approach, we designed and implemented an intervention meeting all project goals, including delivering a preventative intervention without diverting ED clinician resources away from acute care. This required integration of multiple new technologies and processes into existing workflows. These processes can be applied to other use case scenarios involving automated risk stratification or CDS development, which will become increasingly important as EDs harness technology to improve care trajectories for older adults. And I'd like to again thank all of my co-authors, part of the interdisciplinary design team who contributed to this project.